response to that, we did increase the level of income to which we would give people some assistance. Does that make sense? The Medicaid people, they don't need as much help because they've got Medicaid now. They've got insurance coverage, but it's more of the kind of middle class working families of four, and even though they might be making $50,000, they can't afford several $1,000s worth of insurance and hospital bills. So we're trying to get some more help with that segment of our population. So yes, we're glad that the days in the AR came down. Our profit and loss for the year. This is our year-to-date numbers over here. I did show month. We had a good average month. We had a little bit less revenue than we budgeted, but our expenses were right near budget. I did record a healthy amount in interest expense right there as I was reconciling our debt and our interest expense accounts for the year to make sure we're where we'd be at year end, and I did find a few errors that I had fixed. So in our payment reporting. Year over year, our revenue is below budget. However, remember that I took $1.2 million out. I completely separated out Lakeview Gardens. So really our revenue was above budget, but if you include Lakeview Gardens. Contractuals were close to budget. Expenses are all showing well below budget because again, we removed Lakeview Gardens. So we were below budget anyway, but then when you take that out, you're even kind of looking good.
So going forward this coming year, you're gonna have everything split out on a monthly basis instead of having to struggle with this.
Yep, I am. And I'll talk some more about that later. But in the end, we did $1 million more than we estimated we'd do, in spite of the fact that we took Lakeview Gardens out of there. Which naturally, Lakeview Gardens loses money, so it's gonna make the bottom line better, not worse. So that, it was a good year. Any questions on income, revenue? Balance sheet, nothing really noteworthy. The cash went up, the AR went up, liabilities went up. It was just a growth year, expansion year. And nothing big. So, any questions on Lake Health District before we move on? Okay, so now, since Lakeview Gardens is under district medical, we'll move that reporting to district medical section. So this is the revenue. I don't really have a budget number. I don't have a prior year number. It would be sort of complicated to try to separate that out. I might do that at some point when it seems like it'd be a good time. But for now, I'm really working on the allocated expenses. I think that I'll spend a lot of time with our auditors when they're here to make sure that we all agree that those are good numbers, that they're fair numbers, that they're numbers Medicare is going to be, we don't want them to be testing it. So I might end up making some tweaks to that, but I'll let you know. Otherwise, really, Lakeview Gardens lost $75,000 between December 1st and June 30th, which is really totally what we would expect them to get, right, for the monthly.
Cheryl, do you actually have write-offs for contractual adjustments?
Oh, yeah, not very much though, but yes, we
Normally a
do.
daily rate that's paid by government, right? Most.
Right, for the most part, but then you do have private pay and you have some other insurance carriers in there.
We do have some skilled patients that are Medicare patients that will be in, there have been times that we've been too busy in the hospital and then we need to move those patients to long-term care to free up beds, so we'll get some some Medicare patients, not just the Medicaid. And that's why you'll get some.
So, one of the very complicating factors for me in Lakeview Gardens is that their bills are being billed under LHD's, accounting system. So it's in my, we have to separate it out, the bills we send out, the payments that come in, the contractuals that are on them. Their payroll is in our payroll, the AP is paid for our AP. So right now, we're having to separate that all out manually. We are looking at buying a software program called Point Foot Care, for long-term care, and that would allow us to do all of our billing and accounting in that system. So that would make life infinitely easier for me. But so for now, they've got a very simple balance sheet because Lake Health District is doing the work. So they just either owe it to us or we owe it to them. Then moving on to Goose Lake Medical Services, if you don't have questions on Lakeview Gardens. Goose Lake continues to have good revenue growth, going from 30 to 40 to 54,000 a month, average monthly revenue. Let me see if I can catch up with myself. Sorry. Okay, so nothing else to say about revenue. Revenue was good, fairly steady. Net patient revenue, so our increase in revenue year over year was 179,000. Our net for the year, we lost $18,000, so it's really a improving number, greatly improving number. I do believe that if we get a full-time FNP down there, it's going to make a huge difference. Right now, the FNP is working 1 to 2 days a week, and so if we had a full-time FNP, it'll make a huge difference in our revenue. The other thing would be that I didn't rerun the California revenue, but we still that's going to be at or near $3 million for the year, which is a significant growth over the past few years. And for Goose Lake Medical Services, their balance sheet, the problem with this is that last year our AR was 110, this year it's 331. Their days in AR is 180. Unfortunately, really, Goose Lake is kind of at the tail end of our priorities. So with bringing on the new clinics, there have been a lot of billing issues to resolve with them. And we have been in the process of going live with eClinical just this week in Alturas. And so this has taken away a huge amount of our business office staff's time. And this is just not getting the attention that we'd like it to have. Another issue was finalizing the Medicaid contracts. We've seen quite a delay in receiving payments on the Medi-Cal side, so that should resolve pretty quickly. Questions?
So how much is the Medicaid backlog?
I don't really know the exact number, but I'll have to tell you that a great majority of the patients in Alturas right now are PHP patients because we haven't been able to take insurance. I mean, we're getting those contracts in place. We need to start advertising now to let people know. So hopefully we can change that payer mix a little bit. So it's the majority of our payer.
Yeah, that's been a problem all years I've ever been involved.
Yeah, they're not a good place to work with. It's true. They don't pay well either.
Oh, yeah.
Okay. All right. I see it.
Is that it?
Yeah, that's it.
Okay, medical staff privileging. Scott?
Yeah, I guess we got 4 privileges, a couple new, one a radiologist, he was just here yesterday, kind of touring the facility with Dr. Weir, Dr. Brantley. Joe Murray, our CNRNA, and Mark Bradbury, reappointment, and Nora Cockrell, urologist.
I think we saw two of them in our packet, didn't
I think one's, all of them are reappointments except for one.
we? Did you have four?
This one.
Maybe we got them all.
Three dogs and CNA. Charlie, do you want me to comment on this letter?
Not an open session.
Okay, we need a motion on the,
I'll move that we approve the medical staff privileging as presented. Second.
moved and second, those in favor?
Aye.
Thank you. Patricia Annie Johnson Trust Fund, Linda?
Yes, I think Jen sent you the application of Michelle Williams. Michelle is a certified medication aide for us currently, and a former LPN. And she is requesting to go through, the State Board of Nursing allows former nurses and LPNs to go through by means of doing clinical work in a facility. We did this with Reba Swinkle. She was RN who became, let her license lapse, but became licensed. And this is Michelle's request. And the program that is, I think that was sent to you also, is the only one that the State Board of Nursing approves. So there's no options with the variety of costs and programs. So through health and educational consultants, the cost is $2,500 for them. And then she is going to pay for the OSBN reactivation licensure fee. So, but the request would be for $2,500, and out of Patricia Gainey Johnson. She's been a great asset to us, and I think it's great she wants to renew because we can use her then as in long-term care, and Teresa uses some LPNs too, but she can work, actually take a shift as the charge nurse in long-term care. So I would highly recommend that you approve this. She'll go through the hoops.
I'll make a motion that we approve Michelle Williams' application to the Patricia Gainey Johnson Trust Fund.
I'll second that.
Moved and second, those in favor?
Aye.
Aye. Thank you.
Thank you.
Teresa, nursing report.
Well, I'm happy to report that the transition of the cardiopulmonary department, which is respiratory therapists in-house, is in process, and Jenny Henrik Lab will become supervisor of that department. I will still retain sleep lab and pulmonary rehab for the time. We do have a trial going on. You might want to check them out. We have 2 new mobile care stands, computer stands that the nurses are using. That we're doing trials on both of them from 2 different companies. So the cows, so nursing staff have been using them and learning. It's quite a change. Certain things about them are different. And we're trying to get something that suits them and has all the right ergonomics so that it's not too difficult to move and use. We can, NOMA has been tracking med verification rate, which is the scanning of the medication at bedside. And since the carts arrived, we've had an increase from 57 to 65% in the nurses that are using them appropriately. So just to let you know that that's a jump, which is good. We've been working hard at trying to accomplish that for patient safety. And in the surgery area, we did install the CPSI surgery module. That was a big job that Helena has been working on now for quite a while, but it's up and running. The transition isn't complete because some of the billing pieces aren't all in place yet. It's a lot of keeping track of what supplies go in each of the different charge areas. For for a certain type of procedure, that all has to be preloaded. So there's a lot of work that goes into it in coordination with purchasing, but it's nearing completion, so that's good, they like it a lot. Abby Finetti was appointed on the state trauma advisory board. So that's a big deal actually for us as a critical access hospital to have a voice at the state, because they're looking at revising a lot of the trauma regulations and making them very difficult for small hospitals to comply with. So hopefully she will be able to represent us and help keep some of those things from being too hard for small hospitals to do. We do go live with the T system, the electronic documentation system for the ER. We go live for that, with that September 22nd. So we're gonna try that again. You might remember that one was delayed this spring. So, and then lastly, one of the nursing staff, Megan O'Leary Cruz, has stepped up to try to do some of the things that Kathy Burkholder was doing in terms of kind of keeping the OB unit organized and keeping track of things and working on policies and that sort of thing. So she had her first day doing that today. So it's just one day a week. Any questions for me?
If I could just point out a couple things. One, the mobile care stations are cows, computers on wheels, that's how they get that name. It sounds a little, you hate to think of it like that. We have been using the same mobile care station that we bought in 2011. We've upgraded the computers, and now these ones that are being tested are one-touch, so it's ergonomically, it's better for the nurses. They're heavier carts, they have a lot of components on it, but this is the first time we actually changed, and that's why we're doing a trial, to see how that will work. See if we can improve it for our nurses, make it easier to use, which means they'll use it more.
Anybody have questions? We'll go on to the surplus property in the warehouse.
Okay. I believe you got a list of the equipment that we are looking
No,
at.
I didn't see what.
That didn't come up?
Did you send us?
Uh-huh.
Oh, I'm sorry.
So,
Chuck, you need to check your computer.
I know what's over there because I helped haul it over there.
so we have accumulated a lot of material that came in part from when we built the new hospital and remodeled this area. So we have construction materials, we have things that we've been saving that, just in case is lasting. So we have a lot of things that we would like to make available to the community. To do that, we need to have deem them as surplus, so that we can have a garage sale, if you will, which is scheduled for September 14th, I believe is the date. And, September 14th. So we will pull out all the materials, give the public a chance to purchase or bid on, if you deem it surplus. I would recommend that you.
Are you going to try to auction it, or is it just negotiate, or what are you trying to do?
There are a lot of things that I'm not sure we'd ever get a bid.
Jamie gave me the ad to run for when it's declared, and she said a lot of it they're not even going to be able to tag. It's packed so full in the warehouse, and the plan is a lot of it's going to be make an offer, is what she and Justin had kind of
Lots
figured
of
out.
metal cabinets, lots of
Yeah.
doors.
I know, I went over there actually and went, wow. So,
Lots of doors.
Should we allow other nonprofits to go in and have first dibs or anything before an auction? In other words, like senior center or,
We could
It's a huge amount of stuff, Don.
is it?
It is a large amount, and we might be able to pull it out the day before. I mean, it's gonna take a lot of work just to get it out of it. We've been planning on having a sale for quite some time, and we just haven't had time to get it done.
Okay.
So,
There's one or two really nice desks in there, they might be scratched a little by now, but big desks.
Would the Lions take what you don't sell?
We took most of the desks out.
Did you take the desks
Yeah,
out?
the desks are pretty much all even.
Okay.
Yeah.
Can the Lions take what you don't sell? Do they do that?
we could ask, they'd have to store it then,
Yeah,
Well,
but if they're.
that's
willing
the
to do
problem, you know, what they don't get sold, what are you gonna do with it, that's the question.
So, some of them may go to the town.
Yeah,
But it has to be determined to be surplus. That's the first part.
Okay.
I'll make the motion that we approve the surplus of listed items that we were presented online for resale, for garage sale, resale.
I'll second that.
Moved and seconded, those in favor?
Aye.
Aye. Employee recognition, Charlie.
You know, every month I look at ways to find who isn't a stellar employee. We really have a whole lot of really good. And as I look at so many of the people, one area that I'm really proud of is they have a lot of really good staff, and we had a hard time choosing between them. But this individual always has a positive attitude, is enormously reliable, is absolutely the cornerstone of the department, is always willing to help out. She makes our business office function very, very well. It's Donna Moran.
Tomorrow. She's in here a long time.
She's been here, and she does a wonderful job. So we're very, very fortunate to have her.
All right, thank you. CEO report.
Lots of things have been going on. First, since July 1st, when we purchased, or we acquired a Lake County Medical Clinic, we've been involved in the integration of that clinic. It's gone extremely well. And I think that it's due to a large part to our staff that has worked very hard to make it seamless, or reasonably seamless. The business office and Cheryl and all of her staff have done a lot to make that work well. It didn't help that we had, we started on the 1st, on the 6th, we got or 7th, the state inspection came in. So and while they were inspecting the hospital, for whatever reason, they gravitated to that clinic and our other clinics, so spent a lot of time there. Housekeeping, I think all the departments have been working very well with. Staff seems to be pretty pleased with relations, and so that's so far going very well. I told you we had started, we were working on a CNA training program in partnership with KCC. Sorry to say that it didn't work out. It was supposed to have started July 20, and there were all sorts of reasons that it didn't happen. So we thought maybe it could happen last week or earlier this week, and that just didn't work together. So Melinda has been working on a couple of other alternatives, and we are pretty close to having that resolved. If we can get that to work with KCC, we'll do that in the future. That was a disappointment. The survey on July 7 to 10 from the state that was here were 2 people from the fire marshal, 2 people from the state. We just got their report this past Friday, and all the departments are busy working on answering the questions or issues that they raised. Most of the issues, well, in fact, in acute, there was virtually no issues that were of any significance. Most were things like the fire marshal asked that we move the fire annunciator. So if you see a fire, you pull a lever, it had to be dropped or raised by 6 inches. And that was in the clinic. They found that in the design of our hold room, that they were concerned about the smoke detector. And there's a little cage that contains or protects the smoke detector from being tampered with. Should a person be in that room and desire to damage it? Well, they were concerned that that person might harm themselves with this cage, and somehow that might do harm to themselves. I mean, some of the things, I don't know how they came up, but we will be responding to all the concerns that they have. And we have until, I think it is the 14th? Friday?
It has to be
So-
done by Friday.
A week from tomorrow. And so we'll have our responses. We go through a survey every couple of years. These are unannounced, so they show up when they show up. We did have a survey by the Board of Pharmacy, and they found that we had no problems at all. So Teresa Decker and her team have done an exceptional job. So that was really positive. That also is a spot check. Financing arrangements. At the last board meeting, we agreed to work on the refinancing of our debt, and with Washington Federal, Cheryl and I have been working with the attorneys and with the bank to set up the schedule. Looks like we will close, tentative date is October 22. And so going through all the features of that, it's quite a process. We still have yet to get, we've gotten sort of verbal approval from the USDA, but that, because we changed on one of the loans, the smaller one, for $550,000. Instead of asking for parity, Washington Federal agreed. Parity is that in the event we don't make a payment, one bank is in front of the other. They didn't ask for parity. They said USDA could be in front of them. They were okay with that. And since we're buying out the smaller than USDA loans, they didn't think they would have any problem. So we think it's still moving along, working on the documents. Dr. Quinn, the surgeon that will be coming here, he finally got his Oregon license and will be here next week. So he'll be here for it's not exactly yet 3 weeks on, 3 weeks off, but he'll be here for 3 weeks, and then there'll be some adjustments, and then it'll be 3 weeks as he's getting his schedule organized. When he originally made that commitment, he had his vacations and time elsewhere planned out, but it took longer to get his license than he anticipated. Dr. Bradbury is still committed to work 1 week a month, so it looks like we'll have a fair amount of prep. So we're excited about that. We are actively looking for a couple of managers. One is our IT manager, and the other is for clinics manager. Manager over all the clinics that we have. 3 here, 3 primary care, and then other clinics as we bring on more service. So we're getting close to having, so we have lots of candidates. Some are better than others, of course, but looks like we're moving more very well. The update on physician recruitment, Bill Elrick, the nurse practitioner, is going to be here. His license in Oregon is moving along. His license in California, we don't know how long it will take. He's scheduled to be here as soon as he has a license, but no later than in September. There will be GYN that we invited out. We hope to hear within the next week whether we're still in the right. We have 2 other candidates. So we're progressing on that. We also have a PA who has expressed interest, and we're talking with him about that. So we have multiple people who continue to be working. The RARE program, just to give you a little update on that. John Adams has been working on our CHIP program. As you recall, we agreed to sponsor the position of a rare position here. It's going to be paid for by a foundation, Food Share, I believe it is, foundation. But the first round of candidates, we were not selected. The way the selection process works is we get a series of people we can look at and indicate our preferences. Our preferred person chose someplace else. And the others elected not to choose them. Part of it, I mean, we're looking for someone that will do well. I think, as an example, one was really, we thought would do well in a remote setting. One of it that could have been good, we didn't think would do well in a rural remote setting, and we want to have it be successful. The program is to start in mid-February, or mid-September. We expect that we will meet that deadline. We have lots of oral health programs still continuing, where we have the fluoride and the varnish that are sealants. That'll be in this fall and then some in the summer and spring. That keeps moving forward. We had a very good CHIP program in June. It was well attended. Don, thank you for coming. And so that's been moving along. Long-term care project. We need to get a certificate of need. We talked about this, and the state is now sending out a person on the 17th of August. And what they'll be looking for, the reasons why they need to move forward with this, why our existing facility won't work well. In talking to Melinda, she won't have any problem in showing them all the problems in our existing facility. It's normally a 4-month process that will bring us to about October, unless through the expedited process it gets done quicker. We're waiting for the bids back from the contractors, so we can go through that. As soon as we have it, letting you know the status of it. I just haven't seen it from the architects. We have not heard back yet from Weinberg Foundation. And as soon as I know that, they said by mid to the end of August. I just haven't heard back. We will be sending out to you a public meeting and records best practices from the SBA. You've seen that it's a survey that we've all got. So we need to respond to that by, I believe it is in November. So you have time to look at it. We'll be looking at trying to accommodate that.
We did, Judy. It's yearly, and so this one's a lot smaller than last year, so it'll be.
So we'll try to gather as much information so we can do that. Judy has been our representative on the JPIA board. We had a meeting August 1st that we talked a little bit about last week.
Wasn't it July?
July 1st, excuse me, July 1st. I'm sorry. Things are moving fast. After that meeting, we had a meeting of CEOs a week and a half ago. And we're working on a work plan, suggested projects to work on. We'll have our next meeting next week to talk about that and then bring that back to.
Did we get any response to the ad in the paper for a board member?
I know of one coming in the morning.
Oh.
That's all. So far.
I had a verbal request.
Oh.
I haven't had a written request,
Okay.
but that's what I do so far. One of the things that I'd like your advice on, as we look at when we are successful in bringing in the OBGYN physician, we are needing to find a place for that position. One of the things that the survey, the state survey, when it was here, was very concerned about is the mixing of the rural health clinic and specialty service. We're quite concerned that we not commingle that service. And while OBGYN is considered primary care, we need to think about where would be a logical place. I've been thinking that it would fit within, or this practice would be within what is now, was the Lake County Medical Clinic. It would be a great place to intermingle with that. But if the state takes a strong position that it's more of a specialty service, then we need to separate that. The question gets to be where do we put or put this practitioner. The other issue that we have is with the addition of the occupational therapist in this school that will be starting next week, we're getting our rehab service. And as you saw, the volume of rehab has been building. We're having greater and greater pressure from rehab to use where the pulmonary rehab space is. Everybody with me on that? Including two sets of pressures. So as we have looked at what the options are, we thought, well, what would make sense is to move pulmonary rehab to the Strebe Conference Room. That would be a good place for it to, because it would be close to where Teresa Conklin currently is. It would also allow us enough space that we could potentially expand into cardiac rehab, something that Teresa has talked about for years, that would make sense for our community. That would free up the space for rehab and for pulmonary rehab, but it would leave us without the Strebe Conference Room. And while originally that was just sort of, well, let's start using it a little bit, it gets used all the time. And so we are running out of space where we could have conference rooms. And so now trying to figure out what do we do. So one possible solution would be that we lease a couple of mobile buildings, kind of a construction trailer. And one possible suggestion is that we actually get two. And we put them just on the south side of Acute, where the Anderson construction trailer was during our construction. The reason we thought about two is might make sense to move home health from its current location into one of the trailers. That would free up space that we could remodel and put the OBGYN in. And we're still trying to work out what the costs are, but I'm up for any suggestions if you have ideas on what we might, how we might, what other options we might do.
Well, I know it's down the road a ways, but do we have a plan for all of the existing long-term care rooms?
Good question. There's a couple things that we have to keep in mind with that. As part of the certificate of need application, we are currently licensed for 47 beds. When we relocate and build the two coverages, that's 24 beds. So one part of this state is saying, we think that you ought to just relocate 24 beds and keep the other 23 beds licensed. And that would effectively be the north-south link. If that were to happen, then we would remodel just this wing right here on the east-west side.
Of long-term care?
Of long-term care. Another part of the state has said, I think you need to, we don't believe in banking beds. And so that what we're saying is, you're licensed for 47, you're going to be reduced to 24. We're not sure yet, because both have a lot of say within what that license does. And I don't know the answer to how it will fall out. And so it's hard to predict.
What is our census of long-term care now?
Oh, it's 18 today. It hasn't been 47 beds in probably 25 years. And the probability is that we're ever going to have 47 beds filled, probably fairly low, especially given the environment that we have.
It would be nice to have 12 in reserve in case we do get enough business to build another.
Yes.
And so that part of the state, and there's the Department of Health and Services, there's part of the facility planning. I mean, there's different opinions within the state of Oregon's health department, if you will, or the health authority. And some are saying, you know, maybe it's a lot easier to just relocate beds rather than to apply for and get new beds. So that license is a valuable asset, and we really like not to lose it. So when we think about how do we reuse that space, we have a lot of people saying, I have these ideas and I have these ideas. But the need becomes pretty much that as we look at what do we do with these different departments. Because right now they are built. Rehab has really been growing well, as you saw in the statistics.
Well, the trailer concept would be a good short-term answer if nothing else. But I'd hate to see us in a long-term agreement on the trailer.
Most of the agreements are 1 to 2 years. So it isn't like it isn't a real long-term agreement. But repairing the pad is not cheap, remodeling is not cheap. There's been suggestions that we, at some point in time, between Dr. Graham's office and Lakeview Clinic, that courtyard area, that we cover that. But that could easily be a $2 million project. That might help a great deal, but that's a lot of money. And it would take some time to do. So you don't need to respond to that. If you have ideas, that's what we're trying to figure out what are some of our options, what are our solutions.
Well, Charlie, again, this is just kind of a comment, but because it's the Strebe Conference Room and it's named after Dr. Strebe, we need to keep a Strebe Conference Room somewhere, do we not?
We would very much like to keep it. These rooms get used so much, and nursing has been doing a lot of education in the conference room. We've been expanding our CPR training. We've been expanding just lots of different things that the public uses. Other groups use these spaces. It's just, as it's available, people use it. I mean, we really want people to be able to use the facilities here, and it's been well received. So, but we also don't want to do it in such a fashion that's enormously expensive. And
So,
that is-
down in long-term care, the existing long-term care, we've got the cafeteria, we've got a bunch of, what are the plans for those?
Well, if we are able to keep the 24 beds, or excuse me, 23 beds, that would be the long-term section, and we would, depending on how rigorous the state were to say we need to keep all that, we need to have a facility for dining, for community space, and so we'd have to have a door. So effectively, from that entrance to the east is the space that we could use. We didn't have, the concept is, at any given time, any of these offices have to, within 24 hours, be converted to a patient room. We can use them for other purposes, but we have to be able to convert them, so we have to be able to deliver that service. And if we didn't have those rooms, we'd have to deliver that within 24 hours. That would be difficult. And that's the conundrum of this.
That makes sense.
Now, it might be that we could say, sure, that was how we could use that room as a dining room, but also as a conference room, and that would work great. but we can't use that until we have moved the patients out. So that's the,
Well, but are we in a position to where the state will take those 23 beds from us, or can we keep the 47 bed license? Don't we have that option, regardless of a decision? If we have the room to keep them?
that's the position we're taking. We want to get that certificate of need to build the new facilities. If it's a requirement that we have to give up the license, then we have to weigh not doing the project with our demand to keep that license. Because we still have the license, we've not lost it. And so, we want to wait to see, because they've got two different opinions within their own department. And we want to work with those that like our opinion. But I can't answer where it's going to be today.
Okay.
Does that make sense?
Charlie, have we considered home health and hospice as one department that could be moved off campus? It wouldn't, personally, I think it's very convenient to have them here, but is that anything that's been considered,
For example, move them to the Marius building,
well, or something?
or something to that effect.
They have to legally have what's called a storefront, so they have to be, we don't have anything that people are buying per se, but there's some legalities, but it is one, I mean, HR is another one that can be off campus, and another one I would like to see off, but I mean, sometimes maybe those need to be considered, I don't know.
There are many options like that. Business office doesn't have to be physically on campus. So we have some options about it. But one of the things that we look at is if we are going to, say, we want to make things as convenient as we can. If we make our conference room too inconvenient, people won't use it. Or they'll find reasons, a lot of problems with it. We need to have, the nice thing about it where it is right now, it's been a little inconvenient, but not terribly inconvenient. So that's part of the problem with that.
Any other
That's what I,
issues?
unless you have any questions or issues I can address.
I had a quick question. Don was telling me about a committee he's on or not, and kind of an update so the board knows what you guys are doing.
I'll defer to Dom.
It's a secret.
It's a secret?
We're doing secret
Oh.
things.
So it's a patient and family engagement committee, and we are working with the National Patient and Family Engagement Council on that project. So right now we have 5 community members on the project, and then we have Dawn, Teresa, Abby, and myself from the hospital side. And what that committee is for is to hear what the family members have to say about Lake Health District and what we can do to make it easier for them to navigate through our facility. So one project we are working on is creating a brochure of information for family members, so that when they come in, they know who to contact or what the care team is, the nurses, the doctors, how to get in touch with the providers and what are the visiting hours and things like that. And the other very interesting project that came up from the council was that people are sort of confused when they are coming towards the hospital after 8 o'clock on what entrance to use. It is not very obvious that the front entrance is closed and they need to use the ED entrance. So the council is working towards getting an electronic reader board outside. So we have a meeting on August 17th where we will be doing a walkabout outside the hospital to figure out which would be a good spot for us to put it up. So we are working with the maintenance and IT to figure out what kind of electric board would work. And what it should say and everything, we will have to still come up. But that's something very interesting that has come through the council. And this has come completely as the voice of the customers, as you say, the family members and the patients who have been here before. So that's the best part about the project.
Thank you.
What she said.
I did have one other thing that I failed to describe. We had 2 purchases that we were sidelined on. One was we had budgeted to replace sterilizer, one of our sterilizers. And I had signed off on it, was purchased last fiscal year, and for some reason, the signed authorized purchase order didn't get placed and didn't get ordered. It has been ordered. It was for $28,500. So that was not listed in our purchases, but we needed to buy it, it was approved, and so that was a delay. The second thing that has come up is we have a scope that is used on a regular basis. It broke, and we sent it off to Olympus. They said that this 13-year-old scope that is used on a regular basis could be repaired for $8,500. A new scope is $19,000, but if we buy a replacement, instead of fixing this scope, it would be $16,500. So I elected to purchase a new, so now it's not state-of-the-art, but current, better visualization. Rather than repair the scope, this is a scope that the doctors use on a regular basis. We buy it in order. We have in the budget, we put in sort of an estimate of how much surgical equipment, things that we just don't know, they break or we've got to repair them. Sometimes it's proven to have been repaired, other times it makes no sense. So I went ahead and did that. Wanted you to know. Okay.
Any other business for open session? No, we'll take a 10-minute recess and come back and get into executive session under ORS 192-660, paren 2, A, C, and R. Those that will remain will be Charlie, Jim, Patty Baker, I see.
No.
No?
I don't need, it'll be no.
No,